Coffee with Coker, a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. My name is Mark Reibolt. I'm your host of the podcast, and I'm also a Senior Vice President and Director of Strategy at the Coker Group. For those of you interested in listening to some of our previous episodes of the podcast, you can find out more information and listen to all of our past episodes at coffeewithcoker.com. You can also find us on social media at Twitter. You can find us at Coker Group on Twitter, and then you can also find us on LinkedIn. You can search for the Coker Group there. And we have, as I said, more information on past episodes, as well as more explanation and reference material for each episode there. You can also submit questions or suggestions on topics for future episodes. You can reach out to us again on social media or through the website at coffeewithcoker.com. Also, there's an email address you can reach out to us directly. It's feedback@cokergroup.com. And there, again, you can submit questions on anything we've talked about or suggestions for topics you'd like us to talk about in the future. So with that said, we'll jump into today's episode. And this is a little bit of a unique one. So I'm joined today by someone that's been on the podcast before and someone that's always involved in the podcast behind the scenes, but Jess Combs is here. She's our producer of Coffee with Coker. So it's nice to have you, Jess, actually participating. We've received different questions. So this episode is really just a Q&A episode where we're just going to take a little bit of time here to respond to some of the questions that we've received, whether they're directly related to some of the things we've talked about on the podcast before, or some of these things have come in as just kind of questions from individuals and client organizations, and they're common questions, or we thought they're important enough or intriguing enough to where we'd like to maybe drill down and provide a specific response. Most of these, if not all of these questions, will actually be drilling down into even more detail on future full episodes of the podcast, where again, we'll get into even more detail and bring in other experts that know a little bit more closely involved in some of these areas. So with that, we again have a few questions here, and Jess is just going to kind of pose the questions out to me, and I'm going to try to respond to them and hopefully tee up a little information for you all. So Jess, dive in.
All right. Yeah, that sounds good. It's nice to be behind the mic here. So let's start with, I think, a topic that is probably fresh on everyone's minds in November. We have heard a lot of discussion in the media and throughout this election season on the opioid crisis. But I'm curious if this is something significant that'll have a significant impact yet on physicians and medical groups or hospitals. Have you observed any specific instances where the talk in the media in Washington has resulted in major changes, whether they're positive or negative, for healthcare entities?
Yeah, this is interesting when, as we record this, it is election day, November 6th, and I literally just got back from voting. It's definitely this is definitely a topic that has received a lot of attention. And both in kind of the mainstream media, and it's also been a hot button topic in the election campaigning cycle here that we've been leading up to here for really this whole year. And it is something we're starting to see more direct impact of what's going on here. I think broadly speaking, what's interesting here is that I don't know that anything has come out yet that I would say is like a specific thing we can point to where there's going to be a specific impact on whether it's a hospital or a physician practice or an individual doctor. It hasn't gotten that far yet, perhaps. Others may know of things where there is a very specific link to whatever's happening in Washington on this topic, and then, kind of how that's trickling down throughout the industry. But I've definitely noticed multiple things where the buzz around this issue as a whole is starting to play a role in the way healthcare entities do business and go through certain processes. And I'll talk a couple examples here. We actually talked on an early episode, maybe episode 4, where we had Michelle Madison and I were talking about a presentation that she and I gave, and we were talking in that about transactions and M&A and due diligence specifically. Michelle's a prominent healthcare attorney based in Atlanta. We were talking about, again, due diligence, and one of the things that came up is documentation and the compliance matters. And as you're going through a transaction process, some of the things that have come up in as far as compliance and compliance programs and documentation around compliance, those types of things. And there was definitely a number of questions we got there at the conference when we gave that original presentation around what's going on with potential impact of the opioid crisis. And Michelle even alluded to clients she had worked with where there's more scrutiny around documentation on things related to prescribing practices and documentation behind those practices, and having compliance programs or compliance procedures in place to ensure not only are your standards and practices within the boundaries of compliance on this type of issue, but that you have the documentation to back it up. We've seen a lot of, in the last 10 years, tremendous amount of growth in pain clinics and derivations of that, other specialties getting involved into more pain management services. And I believe that the majority of the physicians, the majority of the clinicians out there are good and they want to do good. And they're going to do their job, not just at a baseline level, but at an exceptional level when it comes to caring for their patients. And in most markets that you go into, I believe that the majority of that community knows which ones are the pill pushers, if you will. And that reputation, I think, is it's not always clear, but I think within those local communities, those local markets, obviously there's certain reputations, and I think the majority of people kind of know where some of the different players stand. The majority of the participants within the market are legitimate, but the challenge is, and we've seen this come up through due diligence going into transactions, and what we found is it has less to do with the good ones versus the bad ones. The majority of them, again, are the good ones, if you will. But the challenge is they may not have the documentation to back it up. And there may not be the procedures in place, the protocols in place that set the high standard for compliance. And then they also may or may not have the documentation on the back end to validate that. And so it's not about good intentions. It's not even always about good practices, because I think the majority of the providers out there are in that category of they are doing the right thing when it comes to this. The challenge is they may not always be able to prove it. And unfortunately, I think the direction we're seeing things go to a certain extent from the government's perspective on this issue is a little bit towards that, in the direction of the burden on proof, I guess. And that's where compliance programs are critical, and the documentation on the back end. And so this is definitely something where we're going to see, I think, all physician practices and certainly all hospitals have to step up the game as it relates to what they're doing in terms of their practices, but more importantly, documenting and validating how they are doing or following the rules and within those appropriate boundaries. So I think that's where we're probably seeing this the most right now, and maybe we'll see it here in the near future. It'll be interesting to see after the rhetoric of campaign season dies down a little bit, if that actually will happen, because we are just only another 2 years away from another major election. But when it does kind of settle a little bit, it'll be interesting to see if this issue, it gets quieter on this issue front, or if it's going to be something that just continues to escalate and become more of a prominent focus, both from the government standpoint as well as the public. I think it's not going away anytime soon, though. There's just too much happening on this out there in terms of affecting people, from whether it's addiction or deaths or, just too much negative out there for, I think, anyone to let this issue fade away. Another interesting thing that I've noticed is where we're starting to see this come into play is looking at kind of other types of provider or healthcare services organizations, specifically labs. We work with a private equity firm that was looking at a lab deal, and we noticed kind of a large drop off of revenue concentration revenue that was concentrated on a cluster of customers that was in a single region. Just so happened, it didn't take long to figure out that region was concentrated on kind of West Virginia, Kentucky, northern North Carolina, Appalachia. We know that's been considered the epicenter of the opioid crisis, and you got a lab that's doing a lot of volume on tox screens, and they're concentrated on customers in that region. Significant drop off in revenue. You don't have to be a rocket scientist to understand exactly some of the causation or correlation there. So I think we could see a little bit more of that, or that's just something I think for companies out there to be aware of. There are a lot of directions we could go with that. It's not just the opioid crisis that caused that, but it's definitely tied to it. And so I think we can't ignore it. So I think those are some of those examples where we'll see more of that. I'll just also lastly on this say, one of the Coker team members that you'll be hearing from in the not so distant future is Roz Cordini, and she's an attorney as well as a former general counsel, in-house counsel at a hospital. She's now part of the Coker team, which is great, but she's also a registered nurse by training. So she's a clinician as well as an attorney. And she's dealt with this a lot. She's worked a lot up in Kentucky. She's spoken on this topic a lot. And we're going to revisit this issue here in probably early 2019, I'd say, is when that will come out. But we're definitely going to be talking more about this because we are getting more questions. And certainly, again, I don't think it's an issue that's going away. So it's something we want to stay on top of.
Yeah, it's a fairly interesting topic. So I know we'll be hearing more about it from Roz, just more on compliance in general from Roz, which will be interesting. Yeah, all the compliance is really kind of coming to the forefront these days.
Right.
So
that's right.
All right. Well, let's move on to our next question. And here it is. It says, we have been monitoring the issue around neutral site payments all year, as this could have a significant impact on hospital payments for those entities that have spent a lot of time and dollars investing in outpatient services. Can you comment on what has happened with this issue and perhaps make any predictions as to how the results of the midterm elections could influence the outcome on this issue?
Yeah, another interesting one here, particularly because it ties into a somewhat political, although I think this is actually less political or less driven by the midterm elections, but it's something definitely on the policy side that's a major hot button topic here. And there are again, like most things, multiple perspectives I think we have to look at on this. It's also interesting because I actually, and we can make sure this is available in the show notes, a copy of an article I just wrote. I wrote it for the Journal of Medical Practice Management it's kind of an update on some of the things going on health policy wise. But I specifically talked about this, and I want to talk about it, write about it in the article because it's something that has really heated up throughout the year, but it's definitely come to I think a kind of almost a boiling point with some of the stakeholders behind on both sides of the issue leading into this election season. So real quick, let me just, for those that may not be fully aware of what we're talking about here, I'm going to give the very brief, very high level, kind of dumbed down version of an explanation of what the neutral site payment proposal is, or what this refers to. This refers to a proposal that was made to CMS to consider and potentially approve the changing form of reimbursement for ancillary outpatient services, often referred to as neutral sites, separate from a hospital, separate from a physician practice, professional fee environment. And so we're talking about surgery centers, we're talking about imaging centers to a certain extent. We're talking about, it could be endoscopy centers, renal care, et cetera. And what it would do is, in the past, hospitals, if a hospital owned the majority interest in let's say a surgery center, for those services, for the services rendered at that site, they can be billed at what's called HOPD rates, hospital outpatient department rates, which are significantly higher than if it was majority physician owned and the rates that they could bill out for the same services. And so the idea behind this proposal for the neutral site payments is to equalize those, or actually not equalize them, but bring down HOPD rates to be more in line or directly in line with what they would be for physician-owned entities providing the same services. So this is where I think there are multiple layers to this discussion or this question. And I think, this is a great example of, again, like most things in our world, particularly within the healthcare industry, that this is not black and white. And there are multiple perspectives on this, and there are multiple kind of constituencies that are going to probably look at this issue a little bit differently. And I think that's where some of the conflict and debate has come up. So I think there's a couple things here that we can talk about. First of all, let's talk about the perspective of the hospital. For the hospital, there are multiple reasons why. I think I can't recall which industry group it was that came out, but the most recent estimate that I saw for the first year one impact, 2019, if this policy were to go into effect, it'd be on the low end estimated over, I think it was $700 million in lost revenue or decreased revenue related to these services for the hospital industry. And I guess that number alone, we could debate, okay, what does that really mean for hospitals? How significant is that, et cetera? I don't want to get into that here, but that's significant. I think some of the issue that I've had with this whole discussion is it seems to be a little bit surface level or shallow, in that there's kind of an assumption here that we often hear physicians are frustrated because hospitals can bill out so much more than they can. They enjoy such higher rates. And there's this kind of pitting against each other from the hospital standpoint and the physician standpoint. And what I like to do is try to be a little bit more rational and diplomatic on something like this, and look at it from a standpoint of, okay, why is it that they enjoy such higher rates? Is that just lining pockets? Is that just hospital lobby is that much powerful? Or let's ask even more, in my mind, productive questions. Okay, are the services different? If you have a certain type of procedure that can be done in a hospital-owned facility, and across the street, that same procedure can be done in a facility that's majority owned by physicians, what are the differences there? Is there quality differences? Is there patient experience differences? And are they better or worse? And then I think you have to think about, okay, what are the risks, right? One of the things we've heard from the hospital perspective on this is that, while yes, these certain procedures can be done in more of a practice setting or more of a physician-owned entity, what if something were to go wrong? What are the resources available if the unexpected happened, and it does? Do they have emergency care capabilities? Do they have trauma care capabilities? What's anesthesia? Again, there are a lot of things that gets much more in depth and into a level of clinical discussion and debate that, I really don't want to, I certainly can't speak to, but you hear that. And so I think there's debate there. There's also something that's very legitimate, and I think this is easy to get ignored, but there's the question of cost. Meaning, what is the cost for a hospital to provide certain services versus a physician? And one could argue, well, I'm the patient. That's not my fault. If they can provide it for a lower cost, then the level of quality is still there. Then that's where we should go. And I think that's the biggest issue here, in my opinion. It's not so much about what the payment should be, or trying to equalize the payments or bring hospital payments down to the level that physicians would typically get, or whatever, or even bringing physician payments up. I don't think that's the point. I think I would rather look at this from more of a consumerism standpoint. And if I'm the patient, and that's the other key, I think the most important perspective we have to consider here. And if I'm a patient and I'm able to make an informed decision with transparency and information and pricing, and I can evaluate and assess and have access to the highest quality of care for whatever the appropriate price that I'm willing to pay, well, that's how the market, in my opinion, would ideally be set. Well, and that's how it's set in any other industry. Not to, oversimplify here, but if I can go to a gas station where not only am I getting my gas, and it's the same gas I'd get essentially anywhere else, but I can go in and there's better food that you can get, and there's a selection of things my kids may want there, and there's nicer restrooms for the family to use, and more friendly employees, things like that. Well, then that's going to frame my decision on where I go get my gas, especially if they're right next to each other. Again, I realize it's not the same thing, but in theory, I would rather look at it that way, from that perspective, than trying to just fix pricing. And I'm afraid that's where we've gotten with this neutral site payment proposal. We're trying to confront this issue by simply adjust and fix, basically price fixing. And it's something we've done in the healthcare industry for many, many years. And it's something that I think is driven from the federal government, which I think, again, is kind of dangerous, because these are the types of things that I think would be more productive to set at the local, more granular market level by the stakeholders within that market, and let the consumer ultimately determine what is reasonable pricing for the services they get and the resources or the outcome they expect from those services. And probably what you would find is more of a balancing act there over time, where, yeah, probably some of those prices would have to come down a little bit on the hospital side, on the HOPD rates. And then on the physician side, though, if they can, again, provide the same level of care and enhance the patient experience and ensure the appropriate clinical standards and resources are there, then I think you would see consumers being willing to pay a little more for those. And it's not just consumers, not just patients here. Let's be honest. Most of these things, the patients aren't necessarily quote unquote shopping. Most of them many patients don't even know how to compare pricing or even understand what the cost of and pricing behind many healthcare services are to begin with. It's the insurance companies, it's the payers. And that's where I think this issue starts, is that Medicare reimbursement would be ultimately adjusted. And what we typically see is, once Medicare fees are determined, managed care and private payer rates follow suit to a certain extent, at least, kind of trickle behind it up one way or another, up or down. Anyway, I think that's something that we would see if we kind of let the market balance this out. And I'm not trying to be too naive and pie in the sky here. I realize that can be tricky, but I don't believe the best way of addressing this is simply by forcing rates down for hospitals, because the reality is it's going to cost more for hospitals to provide certain services. They're larger entities. They have greater demand for community services and just more infrastructure. And yes, some of that's on the hospitals. Much of that perhaps is an area where the hospitals have a lot of room for improvement. But a lot of it is, I think it's a little bit unrealistic for us to think that hospitals could provide level of services at such low reimbursement, where if they're losing money on this, then there's going to be a negative impact here. The last thing I'll say on this issue is that, speaking from the perspective of the providers, the physicians, the physician practices, they do benefit from HOPD rates. And let me just say, and this is a broader discussion for another time perhaps, but much of the transaction activity we've seen over the last 10 years, particularly over the last 5 years, where you see a lot of hospital and physician joint ventures, employment, alignment, integration, whatever you want to call it. A lot of that is a major driving factor is the economic benefit that comes from the hospital or the health system owning those ancillary services that can be then billed out at HOPD rates. While the hospital cannot go into those transactions and simply say, hey, we're going to pay you based on the higher rates we get. That is not allowed. That is where we get into a discussion around fair market value and commercially reasonableness on compensation. And the valuation practices that go into those types of transactions cannot take into account in any way what the hospital will make under HOPD rates and translate that into additional or greater kind of a pass-through value for the physicians. However, you can't ignore the fact that, if I'm a physician and I sell 51% of my surgery center to the hospital, now I can bill under HOPD rates. I may only own 49% of that center now that I own 100% of maybe yesterday, but I now own 49% of a center that can bill significantly higher. So I may actually own I may own half of an entity that is billing at a level that I can almost make as much as I was previously owning 100%, if that makes sense. That's just one very simple example where I think the physicians, if we were to go and simply lower or remove HOPD rates under a proposal like this, it's not just the hospitals that are losing. The physicians absolutely will lose. And even if you take away that example, just the fact that this has been such a key driver behind a lot of the alignment and affiliation joint venture activity between hospitals and physicians over recent years, if you take it away, then that's naturally going to, I believe, take away a lot of the drive to do those alignment initiatives in the first place. And so if the hospitals can't benefit from the ancillaries and the higher rates they can get there, they may not have a lot of benefit to go in and align with the physicians at all, an employment or PSA type arrangement. And that's not good. That's not going to be good for the physicians themselves, but it's also not going to be additive, or it's not going to be productive for the level of medical care, medical services that are being ultimately provided in a network type delivery model in a given community. And so I think the community impact will actually be negative for something like this too. So I'm not saying HOPD rates are great and they're the end all be all, but I do think, and maybe this is just me on my soapbox a little bit, I do think this specific proposal is something that's very dangerous, and it's probably the wrong perspective to address this issue.
Well, that sounds like that could certainly be a much longer conversation.
It is, yes. Yeah.
Well, once we get some more final decision, we'll have to come back and do a show all about that.
Yeah, I think we will. And frankly, it will be interesting because, again, this isn't something that we're going to know from the day, from tomorrow, the day after the elections, right, what the outcome of this is going to be. This is not necessarily an election issue. Again, this is a proposal that the federal government has made under Medicare and to CMS that is being considered, and it's really happening at that level. And I'll just say this one last thing. It's actually potentially a little scary in that regard because it's not a voter issue. This isn't something we can go to the polls and necessarily influence, even barring a major shakeup in the makeup of Congress, which I don't think is really going to happen. We'll see, right, tomorrow. Anything short of that, I don't think this particular issue is really going to come down to the voters and the election, which, if you ask me, is kind of, again, another discussion. I won't get back on my soapbox on that. But it will be really interesting to see. I think we'll see pretty close to the end of the year or early 2019 if this does happen. If it doesn't happen, then what's going to be kind of the next iteration of this debate? Yeah.
Well, let's move on to the next question, shall we? I think we have a little change in topic here, maybe to the healthcare technology side. All right, in listening to your episode about what hospital boards should be thinking about when it comes to healthcare technology, we have been paying a lot of attention to the frequent stories that emerge about fines and legal issues, to mention PR concerns, that many hospitals are dealing with when it comes to protecting records, maintaining security in the information systems, and lacking appropriate documentation. But there's so many different facets of protecting data that an organization like a hospital, even a relatively small rural community hospital, has to consider that is challenging to even think about where to start. So how would you suggest a leadership team start to confront this issue to ensure we are protected as much as possible from some of those risks?
Yeah, this is a great question. And just for those of you all listening that may not have heard, this refers to a previous episode. Again, we'll make sure there's a link available to that episode in the show notes. But we did an episode not that long ago with Terry Wilk, who's in our health IT consulting group, and he's also a former hospital CIO, and so has a lot of perspective on this. And it was actually a really good discussion. So I would encourage everyone to go and listen to that. But it's challenging for sure. I think it's something that applies to every hospital management team, leadership, and board, and not just hospitals, by the way. Physician practices have to deal with the same thing. So I think it is a broader issue. I'm not a healthcare technology guy, but from a leadership, strategy, and management perspective, have definitely worked with organizations confronting issues like this. People want to get a little bit more information or speak directly with someone, more detail on this type of topic. I would refer you to both Roz and Jeffrey. Generally, I'll say I think this question basically asks, where do we start? And I think of anything like this, it's I think back to that old cliche around, how do you eat an elephant? Kind of, you got to start somewhere, but it's one bite at a time type thing, which I think is true, right? But I think there are some things here, some overarching kind of perspectives that you can have that may make that process a little more palatable and maybe a little more organized. And I think that's kind of step number one. I think there's 3 overarching pillars. This isn't anything revolutionary, but you got people, process, and technology. And I think in dealing with something like this, you have to think about those 3 pillars and where your gaps might be. And I think a lot of what comes into play here is compliance. So if you set the compliance standards and protocols to begin with, then okay, where do we need to start going in and filling gaps, whether it's the people, on the people side, on the technology itself, or maybe it's on the processes, and or a combination thereof. And you can start getting more specific. Okay, where are those gaps we need to be filling in or addressing where we may have holes? And so I think that's a little bit easier to digest sometimes when you at least can break it down and say, okay, we have the standards set. Here's the compliance program. Here are the standards and protocols that we need to be adhering to and following, and that ultimately kind of guide how we're doing what we're doing. And then we can drill into those areas where we think, again, we need to kind of fill in some of the holes. And so a lot of times I think the reaction, somewhat knee-jerk reaction, not always, and I understand where this is coming from, so I'm not trying to armchair quarterback here, but sometimes we do have a little bit of a knee-jerk reaction and think, oh boy, this is a problem area over here. Let's adopt this software solution to tackle that. But in that process, we don't think about, okay, well, do we have the business practices and business processes that support it and ultimately make that thing work, or to do what we need it to do or want it to do? Do we have the people behind it that can make sure that solution does what we need it to do? So it's not always just a pure technology issue. You got to have those other components. And so sometimes I think it's easy for us to fall into the trap of, we think this solution over here, this tool, this resource, this technology is going to kind of be the silver bullet, and that solves our problems. And if we just write the check for it, then magically that issue will go away and it will be done. And of course, that's just not how it works. So I think that, I think if we look at it from a bigger picture, let's make sure the standards and protocols are set appropriately first. And then you can have a little bit more of a systematic approach, looking at all 3 of those components: people, process, and technology. And that's probably the best kind of overarching broad response I can give to something like this. And I think the question was, or I think it seemed to be from the perspective of kind of a senior management team, senior leadership, board level type perspective. And I think at that level, that's where it has to start, because you don't want your board going in there and saying, hey, we need to get in the details on this, when maybe you haven't figured out what really needs to happen at kind of that bigger picture perspective first. And so from there are a lot of different directions you can go, though, to tackling this issue. It is a major issue, and it's something that really, it's not like you're just going to go through a process and say, oh, okay, we solved it, we're good, move on now. It's going to be an ongoing thing. And so again, that's why you need the structure, the formation, the infrastructure, the leadership behind it, so that you can manage it efficiently and effectively on an ongoing basis. But again, I know both Jeffrey and Roz are going to talk a lot more about this. They've done a lot of work on this. I know we've written other white papers and articles about this as well. So feel free to go back and look at some of those things. And again, reach out to us if there's something specific you'd like to talk about with either Jeffrey, Roz, or anybody else on the team.
Yeah, I think, just going back to a point real quick, I do think that people often underestimate the impact of culture and processes and even accountability that things can have on this type of thing. I mean, you can look at that a little bit more broadly, if you will, as well. But like you said, just finding one software solution just because you implement it does not mean that, you have the culture there to address the processes and having people actually utilize that.
Yeah, that's right. I mean, it's something that it happens in every organization. Let's face it. I think we've seen a lot more attention on this type of thing, meaning data, cybersecurity, and data integrity, document integrity, however you want to put it, with hospitals, because it seems like every week there's a new story about some data breach. And obviously that's a big deal. And it's something that every hospital has to deal with. And let's face it, there are a lot of different points where things in the process, when you're thinking about those types of organizations and how big, complex, many different facets related to them, there are many different places where things can slip through the cracks, and ultimately you get exposed. Again, it's something you're always going to have to stay on top of. And oftentimes these types of things can start relatively small. Like you said, Jess, it's, kind of, it can be a culture thing. It can be a leadership thing. It can be a process thing, whatever. But a lot of times it starts small and seemingly insignificant. And then all of a sudden you realize that's just got, it led to some really major exposure situation that now you're having to scramble to address. And so, yeah, it's major. It can creep up on you, and every organization has to deal with it.
Yeah, well, hopefully that's not the snowball situation. It's something too many people will have to deal with, but you never know. All right, well, on to our next question. Let's see. Our organization has been struggling from revenue stagnation and even drops in some cases that we know are not tied to negative changes in our payer contracts or fee schedule changes, expense management, or even the billing and collections component of revenue cycle. So we think the issue could be related to coding. However, in the past, our focus on coding has mainly been just to ensure our providers are not upcoding. So how could issues around coding play into the broader revenue cycle management type of procedures?
We've been doing a lot more as it relates to coding, and we've received a lot more, questions and inquiries related to broadly speaking, coding. I think we have to address that to start with on this question, because first things first, let me just say, I look at coding. So Coker has done coding related services for many years. But there are kind of two components to quote unquote coding services or coding issues. There is looking at coding issues from a compliance standpoint, and then there's looking at coding issues from an optimization standpoint. And the two absolutely or certainly are not mutually exclusive. And there's linkages between the two in many different turns. And so let me explain further. The last point there, or one of the last points there, is related to their focus on coding historically has mainly been what I would say is kind of downside protection, risk mitigation as it relates specifically to upcoding. And that's very common. We've seen that for many years. You get organizations that, whether they've been dinged on coding practices or they've learned about other organizations going through that process of getting penalized, whatever it may be, you get, I think a conservative perspective on coding is healthy, but there's a little bit of a fine line, I would say, between conservative and hyper-conservative. And hyper-conservative can be sometimes just as dangerous, because what it can do is lead to downcoding. And I'm not a coding expert, but I at least know enough about billing, collections, rev cycle, and clinical documentation that I can at least say downcoding is just as bad as far as the legal regulatory framework on the topic goes. We've seen a lot of our coding services in the past on the compliance side start with a chart audit. And, we have to red flag downcoding issues the exact same way we would upcoding. And so you have a lot of organizations that there's a hypersensitivity to upcoding to the point where downcoding has become a problem as well. But that's a compliance issue. It sounds like in this scenario, what the person is talking about or asking about here is beyond the just compliance issue and kind of looking at it from an upcoding standpoint. Perhaps they've suffered a little bit from that hyper conservatism on coding practices, which, by the way, I think can be addressed. It's not necessarily an easy process, but it can be a relatively simple process to alleviate that kind of mindset in an organization. But it goes beyond, I think, the compliance discussion and potentially into the optimization category. And so, if you can go in and you can correct some of the mindset issues that may be there related to upcoding versus down, the conservative, hyper-conservative scenario, and through education practices and, streamlining more efficiencies and coding practices, coding departments, personnel, et cetera, you can kind of rectify some of the upcoding, downcoding issues and even out that bell curve to be more consistent with where it needs to be. Then you get into, okay, where are we still maybe perhaps leaving money on the table? And for a healthcare organization, listen, they named it here. There are only a few places, I think, where you're going to see significant dollars loss or gain. Changes in payer contracts, they mentioned. Fee schedule changes, kind of same thing. Managing expenses. Yep, obviously you got to do that. You can do that to a certain point and run a tight ship, but then, again, there has to be a balance there, like any organization. The rev cycle process, billing and collections. Yes, absolutely. How well you bill, how well you collect. But before you even get to that, you have to deal with the coding issue. And so, yes, we want to be within the appropriate boundaries of the bell curve. And this is specific more to E&M coding, but the same applies to inpatient and other types of coding. But you want to be within the appropriate bounds of that bell curve. As far as not upcoding, not downcoding. But then there's kind of the next layer. How can we maximize the accuracy, maximize the effectiveness of our coding practices? And that's where you get into the optimization discussion. And there's far more here than I could probably address, for right now and kind of a quick response. But I think it's definitely something that we're seeing organizations gain a competitive advantage in that, if you're not able to gain much more through growth in fee schedules and payer contracts, you've kind of you manage expenses well, or you've reduced costs as much as you possibly can. And, you got the billing collections process to a good level of efficiency. Then, okay, where can we gain a little bit more? And I think that's where, again, you can really tighten up that coding process and those coding practices. And I think it actually goes back to how I responded to one of the previous questions. There's a people component here. Who are the people involved in coding? There's the clinicians that are involved in coding, and that's something that you got to stay on top of from an education standpoint and information standpoint. Your clinicians are very busy people. You don't need or want them to spend all their time staying up to date on the latest changes in coding standards and practices, and more than that, getting in and dissecting how with every single patient and every single chart how they can maximize that. That's not what they're there to do. But can you have people in place that help them, that assist them in being able to stay up to speed on that? And that's where your other people come into play, whether they're other people that are directly involved in the actual coding process and dealing with charts, or is it kind of a program to stay on top of education and information for those providers that are doing the detailed work in the charts and the code. And so that's something that I think you have to stay on top of. And then there's the technology component here. What is your technology infrastructure and data information systems? What are they doing for you as it relates to improving and making your coding process more efficient? And there are solutions out there, but there's also just kind of things you can do. Probably use your existing technology infrastructure and information systems to enhance that process, to maximize the value you're getting out of that process. So the people and the technology work more efficiently together. And then the last one, again, that third pillar, the process component. What are your processes? What's your infrastructure and protocols? What are those things that are in place that ensure you're not just within a broad range of boundaries on upcoding versus downcoding from a compliance standpoint? Obviously, you want to do that, but to really hone in on and maximize the value you're getting in there and making sure that you're within tight boundaries of coding practices that allow for kind of greater value to come out of it. We're seeing a lot happen there, and we're doing more there to I think increase value and there to a certain extent. I don't think low-hanging fruit is the right term, but it's kind of what I think of here, that I think most of your hospitals and practices out there would be able to achieve newfound dollars pretty quick if they would go in and maximize this process. And then from there, building a program allows them to maintain it effectively. And again, there's a lot here. Obviously I think every organization's situation is different, obviously. So what this particular organization may be dealing with, it's not going to apply the same, but I do think there is a significant opportunity for value in most of your, or certainly many of your hospitals, many of your practices out there as it relates to coding. And it's not just a compliance issue. I guess that's the biggest overarching point here. It's not just a compliance issue. There's a rev cycle optimization component to this that I think sometimes is missed or overlooked. That's a great question.
Yeah, there was a lot to dig into for that. There's been a lot of really good questions. So, All right, well, let's kind of roll into our last one because it looks like this one might be a two-parter. So.
Yeah, which is fine.
All right, so our last question is, as it has become commonplace to see hospitals buying physician groups, some local markets have seen significant shifts as a result of larger groups selling to hospitals. At the same time, new players such as large corporate systems or groups backed by private equity investors are entering markets and competing with the hospitals for acquiring major physician groups, which can significantly shake up the dynamic between the physicians within those groups and the hospitals they interact with on a regular basis, especially at the local level. So my question is twofold. One, have you seen this take place? And two, how might this trend potentially shake up local healthcare markets more in the future?
Yeah, a lot to unpack there. I like the topic. This is definitely something that applies to kind of my specific personal level of experience and focus areas. So I like it, but there is a lot here. And it is something that, yes, we are seeing. We are literally, today, right now, working on deals where this type of dynamic is occurring or coming up. And they do mention kind of a couple of different things here. The impact on local markets, local healthcare markets from physician and hospital deals, particularly when you're talking about deals involving large physician groups that have a major market presence. That happens particularly in specialties, surgical specialties, things like that, where, one transaction can really shake up market share significantly. And as a result of that, we've seen more involvement, more, just monitoring even from, federal government, the Federal Trade Commission, FTC, things like that as it relates to antitrust, because in the past, antitrust has been more of an issue when hospitals merge. But now we're seeing, if a hospital and a large major physician group that represents significant market share in that market, then and they come together, how is that potentially impacting the market dynamics? So again, and I think that's another topic for another day. I don't want to maybe sidetrack too much on that, but it is a relevant component here. But they also talk about the which I think is kind of most interesting here in this question, is the influx of activity and attention from private equity. And this is definitely something we've seen. So, for the first few years of the hospital physician consolidation trend that really started 10 years ago, and in terms of kind of the wave that we've seen and we're still seeing today, it really was more hospitals and physicians, and it's kind of a local market thing. Certainly, there have been more kind of corporate sponsors, if you will, that have gotten involved in partnerships, affiliations, joint ventures with whether it's physicians or sometimes with hospitals. And that's always been a thing. And of course, you have the for-profit hospital players that are technically investor-backed as well. So they're kind of their own component of this. But specifically private equity investors, we've seen a lot more activity here. And I'm gonna this is probably it's definitely something that we're gonna have a follow-up episode on and address further. So I'll just cover it from a high level since they asked. And I don't want to ignore it, but I'll also use it as an opportunity to put a little teaser out there so stay tuned and stand by for more information on this particular issue. And actually, I just wrote an article, I think went out in the Coker Connection newsletter. So hopefully you're subscribed to that, but if not, you can find it on our website. And so bottom line though, we definitely have seen an influx of private equity coming into healthcare services. And in some ways, we've seen a higher concentration within certain specialties, certain areas. We've seen a lot in, just to name a few examples, but it's really across the board. But again, to name a few that stand out, dermatology is one. We've seen a lot of it. We've seen on the dental side, ophthalmology is one. We've seen some in some of the surgical specialties or in subspecialties like GI, ortho. I'm just trying to think. And then we've also seen an influx of activity even recently on primary care. And so we've seen internal medicine practices being bought out and employed by private equity backed sponsors. We've seen also on peds. We've seen it. Peds, we've seen it actually for a number of years, and some OBGYN as well. But I think what's interesting here, not only is this taking place, and this is where I think some of our follow-up discussion will focus in on is, okay, if private equity can come in, and let's face it, a lot of time private equity can come in with significant capital resources. They don't have the same obligations from a community benefit standpoint and other activities that they're involved in that a hospital in a local market would have. And so they can write big checks. They're not always kind of bogged down with other obligations and heavy cost structures, infrastructure, things like that. And they're also, in many cases, new market players. So they can come in a little bit of a fresh market entry, hit the ground running with an acquisition, that they can quickly deploy additional capital resources to grow and expand. So you come into a market, you have a platform with one major group, one major acquisition, and you can quickly, rapidly grow that, scale it throughout a particular market, even expand regionally. And that is where we've seen a lot of this happen. And that does have an impact on the local market. One of the things I think is interesting here, they also go on to ask, not only shaking up the local healthcare markets, but can the hospitals compete with these players? And again, that's something we're going to talk about when we talk more about this in the future. But I think, I think they absolutely can. Again, it seems for some hospitals, and if this type of scenario were to confront some hospitals, it may seem like, well, there's no way we compete with them, whether it's a financial capital constraint issue. It may be a fair market value, kind of regulatory legal constraint you're having to deal with, or it may just be your organization is not equipped to compete with that type of other player. But it's not impossible. And so I think there are ways, and I think we're starting to see deals structures become more innovative, still, of course, within the boundaries of regulatory and legal guidelines and requirements. But, a hospital doesn't necessarily just have to assume, well, if a group of physicians is talking to a potential buyer that's from private equity and that's, promising big dollars, it doesn't necessarily mean that they can't compete with that. And so my response to this, again, we'll go into more detail in the future. So I could talk about it for a long time, but I'll be as succinct as possible and say, at least at this point, don't assume, if you're looking at this from the hospital side, don't assume you can't compete with private equity. If you're looking at it from the physician side and you're in a group that's maybe considering a sale and you're assuming that private equity is the only way you're going to get the valuation you're looking for, or the kind of financial terms, the buyout terms that you and your partners want, don't just assume private equity is the only option. I think you absolutely should consider alternatives, and one of those alternatives would be the health systems, the local players within your market. Now, every market's different. I get it. Every physician group is going to have kind of a different dynamic with different hospitals in their market. Same thing on the hospital side. They're going to have different dynamic with the various physician groups in their market. So there's a lot of nuance here. Obviously, the devil's in the details, like with anything else. But if private equity would make a mistake anywhere, it would be coming into a market and assuming, they can just drop a big check or promise big check and assume the deal is done. And if that's the only thing driving any group doing a deal, then my recommendation would be maybe take a step back and think about some of the other factors. And then, and again, consider a process that really allows you to identify and evaluate all of the alternatives. And certainly, if nothing else, you may end up doing the deal with private equity. And by the way, it's not a bad thing to go and do the deal with private equity necessarily. I'm not saying they're the bad guy here. In many cases, that is the best option. But if nothing else, I would want any group out there, any organization considering a transaction, particularly a sale, to at least have gone through a process where they can say, okay, we were able to identify all viable alternatives, and we considered them with appropriate due diligence, and this decision we're making is the best one. And so it's not always, again, as I kind of said in an earlier response, it's not always black and white. Each deal, each market, each stakeholder involved in a transaction is different and unique. And there are unique perspectives from every side. And so, I think though, the first thing we don't want to do is just assume, hey, we can't compete, or this is our only option, or it's guaranteed just because they can write a big check. That's the route we should go. So again, we'll be talking more about that. I know I said it before, but yeah, we're going to be drilling into this issue more because we are seeing it come up. And I think it's interesting that the question came up, and look forward to having that discussion.
Yeah, no, that is an interesting question. And if I could take 2 minutes and kind of throw a curveball at you, it just kind of occurred to me, this seems like a relatively new trend. So what's the allure of the private equity investors? Like, why are they all of a sudden deciding to get involved in healthcare?
Yeah, it's a great question. It's funny. I was talking with a group recently of partners from a private equity firm, and they've really stepped up their focus and resources they're putting towards healthcare, particularly healthcare services. We were talking about that, and I think, there's a couple things on the surface, and probably the broadest response to that is, I think everybody wants a little bit of piece of the healthcare pie. You see the numbers. Look, healthcare is not going away. We spend it continues to be a bigger and bigger portion of our GDP. Where our money and our federal dollars are going, and the attention from the federal government, state governments, and federal and local policymakers. So it's an issue. We also have the demographics, the nation's demographics, of course, that we know and we've seen for years, the aging population. So, healthcare as a industry will never go away. And right now, because of the demographics and population trends, economic trends, it's only growing, and it's growing at a pretty rapid pace. And if and when healthcare growth does balance out, it's still going to be on an upward trend. So as a result, everybody kind of wants, particularly your institutional capital sponsors, your large private equity firms, investment banks, Wall Street, et cetera, they all want a piece of that healthcare pie. And so you can kind of see why just for that reason alone. But there's also there's a nuance in that too. And again, we can probably talk about this all day, but just a couple of the things that jump out, healthcare is highly regulated. So there's a lot of waste. There's a lot of bureaucracy. There's a lot of things there's a lot of room for improvement in healthcare. And so if you think about all the dollars and the investment that goes to healthcare today, there's so much to be gained. And that's why you're seeing players like completely outside the healthcare world, like, Amazon and Warren Buffett, Berkshire Hathaway, and JP Morgan teaming up to do something. Google is in healthcare, Apple is in healthcare. The growth of technology that's translated into healthcare. It's amazing when you look at some of the numbers that are behind not just the activity, but the value, the dollars, the economic components going into the healthcare industry. And so there are a lot of ways, there's a lot of room for value, and healthcare historically has never been the most efficiently operating and innovative and progressive of industries compared to other industries. And so there's so much room for improvement that I think a lot of people want a piece of that as well. And then finally, I think is directly to your question on why is private equity interested in healthcare services. That right there is one of the areas I think that historically we didn't see. We've seen a lot of private equity invest in healthcare technology. We've seen a lot invest in kind of what I call allied health, which is everything from, rev cycle management companies, billing companies, management companies, payers. On the healthcare payer side, we've seen a lot of that. And we've seen a lot of capital go into a lot of the other components of the healthcare industry. Now I think they're seeing, oh, wow, there hasn't been a lot of, at least not to the same level of capital go into the services themselves. And a lot of that, there's, again, different reasons there. But now I think we're entering into a world of, the investors are confronting it in a way that, they want to get in. If they're going to get in, they want to get in and do it right and deploy the capital, the resources, the people, the leadership, the technology, whatever it may be, to go about this unique business correctly and effectively from the get-go. And then you're seeing the provider world being more open to that and say, hey, I could partner with, I never had the opportunity to partner with a large, capital sponsor that not only can write checks, but they can bring in other resources, other business practices, other scale opportunities for growth that we just can't achieve on our own. So I think the healthcare provider world is a little more open to it as well. And so it's something that we're still a little bit on the early stages of it, but I think it's definitely going to grow. And I think, we'll see how some of these deals go and being, if they're validated and if and when they are, I think you're only going to see more of it. So there are a lot of dynamics going on here, but yeah, it's, I don't think it's something that's going away, and, it may go up and down a little bit. There may be a little volatility to it. Again, we're probably going to continue to see a little bit of concentration in certain areas where there is less risk perhaps than other areas. So they can kind of make those work and validate those and get home runs, and then maybe go back and consider stuff that's a little more innovative or a little pushing the threshold on the risk chart a little bit more down the road. So that'll be interesting to see even how this evolves. Yeah,
definitely. Well, I think this has been a pretty good discussion here. We had a lot of really great questions. So
yeah, they were all great questions, but I think they covered an interesting array of topics. And, again, I like to hone in on these because it's stuff that we either have talked about or we'll be talking about. And so stay tuned and stand by for more. But in the meantime, people can always reach out to us for more details, or if there's anything else we didn't cover. We always encourage people to continue to ask questions and submit recommendations for things they'd like to hear us talk about.
Great. Sounds good.
Thanks. Well, thanks for listening, folks. We'll catch you on the next episode. And again, reach out to us if you have any questions or recommendations for things you want to hear about in the future. But until then, thanks for listening. We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.